Fascicular blocks. The primary ECG change in left anterior or posterior fascicular block is a shift in the frontal plane QRS axis, oriented in the direction of the lastly depolarized myocardial region. Axis deviation is due to loss of the opposing activation forces in the blocked fascicle, which normally balance the forces in the other. On the other hand, the QRS duration is not prolonged in fascicular block. The left anterior fascicle is the most affected. The most affected fascicle in isolated fascicular blocks is the left anterior one, because it is very long, very narrow, and more subject to ischemia. Normally, the activation forces in the anterior and the posterior fascicles oppose and balance each other. Left anterior fascicular block. The left anterior fascicle normally initiates activation in the upper part of the septum, the left anterior papillary muscle, and the left ventricular free wall. Activation sequence in left anterior fascicle block. Early forces, unopposed activation via the left posterior fascicle, directed inferiorly. Late forces, directed superiorly. ECG in left anterior fascicle block. In leads 2, 3, AVF, initial inferior forces result in small r waves, while late superior forces result in deep S waves, hence, small r deep S pattern. In leads 1, AVL, initial inferior forces result in small Q waves, while late superior forces result in tall R waves, hence, small Q tall R pattern. In leads V5, V6, initial inferior forces result in small Q wave if they are also directed to the right, while late forces result in tall R waves, superior forces, followed by deep S waves, delayed activation of the high lateral wall, hence, small q tall r deep S or tall r deep S. This figure illustrates delayed activation of the high lateral wall in left anterior fascicle block. In V2, V3, initial inferior forces rarely result in small q waves if they are also directed to the left. The mean frontal plane QRS axis is characteristically extremely leftward, beyond -45 degrees. Left anterior fascicular block. In leads 2, 3, AVF, small r, deep S pattern. In leads 1, AVL, small q, tall r pattern. In leads V5, V6, tall r, deep S, with or without small q. In leads V2, V3, small q rarely occurs. QRS axis, characteristically extremely leftward, beyond -45 degrees. Left anterior fascicular block. Can simulate left ventricular hypertrophy, LVH, in leads 1 and AVL, due to tall R waves. Can conceal LVH in V5 and V6, due to presence of deep S waves. Can conceal inferior myocardial infarction, due to presence of initial R waves in inferior leads. QRS duration in left anterior fascicular block. Because of the multiple interconnections between the fascicles of the left bundle branch system, left anterior fascicular block does not increase the QRS duration by more than 0.025 seconds. Left anterior fascicular block pattern with prolonged QRS duration generally indicates the presence of additional conduction disturbances such as right bundle branch block, myocardial infarction, or nonspecific intraventricular conduction disturbance due to diffuse fibrosis. Left posterior fascicular block. In leads 1 and AVL, early forces are superior and to the left resulting in small R waves, while late forces are inferior and to the right resulting in deep S waves, hence, small r, deep S. In leads 2, 3, AVF, early forces result in small q waves, while late forces result in tall R waves, hence, small q, tall R. Characteristic right frontal plane QRS axis deviation beyond 120 degrees, because of delayed depolarization of the areas normally activated by the left anterior fascicle. Left posterior fascicular block is almost always associated with right bundle branch block. Isolated left posterior fascicular block is extremely rare, and a firm diagnosis requires that other causes of right axis deviation have been excluded. Consequently, the diagnosis of pure left posterior fascicular block cannot be made from ECG alone, because a similar sequence of ventricular activation can also occur in right ventricular hypertrophy, pleuropulmonary disease, acute or chronic, and in extremely vertical anatomic heart positions due to a slender body build or chest wall deformities. Compared to the normal QRS axis found in the normal semi-vertical heart position, right axis deviation may just occur due to extremely vertical heart position. In right axis deviation, the QRS complex is dominantly negative in lead 1, and dominantly positive in lead AVF. Additional clinical, radiological, or pathological information is needed, to exclude other causes of right axis deviation. This figure explains QRS axis deviation in fascicular blocks. In left anterior fascicular block, the anterosuperior portions are the last to be depolarized, resulting in left axis deviation. The situation is the opposite in left posterior fascicular block, where the inferoposterior portions are the last to be depolarized, resulting in right axis deviation. Left septal fascicular block. Normally, the ventricular septum is activated via the septal branch of the left bundle branch, and its activation vector proceeds to the right, creating R waves in V1 and Q waves in the lateral leads, and anteriorly, creating Q waves in inferior leads. Left septal fascicular block can lead to loss of septal forces, shown as loss or diminution of septal R wave in V1 simulating septal myocardial infarction. This pattern is sometimes also seen in normal individuals. Loss of septal Q wave in one or more of the lateral leads, 1, AVL, V6, and inferior leads, 2, 3, AVF. Occasionally, left septal fascicular block may lead to a gain of anterior forces, particularly when associated with right bundle branch block, seen as tall R in V1, simulating true posterior myocardial infarction. In left septal fascicular block, the QRS duration and axis remain normal, as activation of the left ventricle via the left anterior and posterior fascicles is undisturbed. Thank you.